Assalamu alaikum everyone. I am Dr. Muneeba Ahsan Sayeed, and this presentation is about the 7 Ds of antimicrobial stewardship. Antimicrobial stewardship, its basic idea is to give the patient the right antimicrobial when it is needed. It will help in preserving antimicrobials, decreasing the incidence of antimicrobial resistance, improving patient outcome, and decreasing hospital stay. The 7 Ds of antimicrobial stewardship are the following, and it is very important to know all the 7 Ds before prescribing any antimicrobial agent. The first D is disease, second drug, third is about dose, fourth is about duration, fifth is de-escalation, sixth is diagnostics, and seven includes discontinuation. So the first question is, does this disease need an antibiotic or not? If you are, what are you dealing with? Is it a viral or a bacterial illness? So if someone is coming to you with fever, cough, runny nose, and body aches, it's likely a viral illness, and there's no point of giving an antibiotic. But if someone is coming to you with dengue fever, obviously there is no role of an antibiotic in that case, unless you are suspecting a secondary bacterial infection. The D2 is drug. So what's the appropriate drug to treat this? Is the bacteria susceptible to it or not? D3 is about the dose. So what's the recommended dose? For now, you have to mention the dose is milligram or gram, and along with the frequency, once daily, twice daily, 3 or 4 times a day. Then the duration of therapy. So what's the recommended duration of therapy for the disease you are treating? If you are treating cystitis, the duration of therapy is 3 to 5 days. For complicated UTI, it's 10 days. For pyelonephritis, it's 14 days. For pneumonia, it's 5 to 7 days. For gram-negative bacteremia, it's 7 days. For gram-positive bacteremia, it's 10 to 14 days. For infective endocarditis, if it is a native valve, it's 4 weeks, while for prostatic valves, it's 6 weeks. D5 is de-escalation. Can the antimicrobial be switched from IV to an oral agent? So the antimicrobials with good oral bioavailability include fluconazole, quinolones like ciprofloxacin, moxifloxacin, levofloxacin, trimethoprim, sulfamethimazole, and linezolid. So if the organism is susceptible to any of these agents, you can easily give the drug in oral form because it has got very good bioavailability. Then the second question is, after culture reports, switch to antibiotic, which is appropriate and has the narrowest coverage. For example, you have empirically started someone on meropenem, and later the tracheal culture is showing pseudomonas, which is sensitive to ceftazidime, piptaz, and meropenem. So always de-escalate meropenem to ceftazidime because it has the narrowest coverage. Then use the diagnostic test to make a diagnosis. Always send cultures before prescribing any antimicrobial agent. The T7 is discontinuation. So the question would be, has the infection resolved? And if so, you have to stop the antimicrobial agent when infection is treated. Antimicrobials are not supposed to be given for an infinite period. There is a term called antibiotic timeout, in which you will reassess its need after every 48 to 72 hours. And come out of the fear that stopping antimicrobial agent can lead to a poor outcome. So these are the seven Ds. Next time, whenever you prescribe an antimicrobial agent, think about all these 7 Ds. And the take-home message is antimicrobial stewardship. It's everyone's responsibility, be it clinicians, pharmacists, administration, infection control team, patients, and public. Hospitalization or ICU admission does not warrant initiation of an antibiotic, and never dispense antimicrobials without authorized prescription. Thank you for your time.